Hi, my name is Kendra Flores. I'm a genetic counselor at the Helen F. Graham Cancer Center, Christiana Care. I want to first thank the Delaware Breast Cancer Coalition for welcoming me and for offering to have me give this talk. Today, I plan to speak about observations and treatments in the field of genetics. I have no financial disclosures to disclose today. So, getting right into it, the questions that I plan to answer today include: how often is cancer genetic? And what are the sort of genetic tests that we do in cancer genetics? How do these genetic tests impact clinical care? Who's eligible for these sort of tests? And finally, I want to touch upon the sort of genetic testing that you might be able to order on your own and whether or not we find that that's a helpful tool in the clinic. So, getting right into it, what percentage of cancers really are genetic? All of them. I want to thank you for coming to my TED Talk. No. Okay. So most cancers are not hereditary, but all cancers are genetic. Only a subset are hereditary. What do I mean by that? Today, I'm going to talk about the difference between a genetic cancer, which is all of them, and hereditary cancer, which is what I, as a genetic counselor, focus on. So, what do I mean when I say that all cancer is genetic? Well, let me super simplify it. Everybody knows that there are things that we are exposed to that can lead to cancer. No one's going to be on this earth without some sort of exposure. So if I simplify it to environment causing cancer, I'll complicate it a little by saying that we have genes in our body that their job is to suppress the growth of tumors. We're not really creative with how we name things in science. So we in science call these tumor suppressor genes. And genes that you may have heard of before, like BRCA1 and BRCA2, are examples of tumor suppressor genes. They stop our body from growing tumors in some way, shape, or form. And we have a copy of tumor suppressor genes, one from mom and one from dad. So we have two copies of every gene, including these tumor suppressor genes. And at that level, all cancer is genetic. When we get cancer, these environmental factors, which are normally suppressed from causing cancer by our genes, are in some way still able to cause cancer, and cancer happens. That happens because over time, these protective genes degrade. Mutations can arise in these protective genes over time. And when these protective genes are no longer there and protecting us, we're susceptible to cancer. When this happens over many, many years and the progressive degradation of these genes, that's called sporadic cancer. Compare that to hereditary cancer. That happens when instead of having a copy of this gene from a mom and a copy of this gene from a dad, only one of them is working. And that difference, that mutation, can be inherited from mom or dad. So that inherited difference causes one of the protector genes not to work from birth, from the very beginning. And so without that protective gene, you only have one copy. And again, over time, as it degrades, that one copy breaks, and all of a sudden you're susceptible to cancer. That's called hereditary cancer. To look at it a different way, in a person who doesn't have a hereditary cancer syndrome, they're born at birth with two functioning protective copies. And let's say over 40 years, damage happens to one of those copies. And then over another 20 to 30 years, damage happens to the other copy and cancer happens. In a person born with a hereditary cancer syndrome, they're born with a loss of one of those genes, a mutation that causes that gene not to work. So over those first 40 years, a damage to the other copy might happen. And then without any protective gene there, cancer can happen. This is a thing called Knudson's 2 hypothesis, and it's the basis behind hereditary cancer counseling and genetic testing. Looking at it this way, about 10% of cancers fall into that hereditary category, meaning that when we do a hereditary genetic test or a germline genetic test that I'm going to talk about today, we would be able to find a single gene mutation that's being passed down from generation to generation that's responsible for the cancers in the family. Most cancers fall into that sporadic category where it's over time, that progressive loss of cancer protection that happens over just time. And that's why age is the biggest risk factor for most cancers. Familial is in between hereditary and sporadic, where we think that there's an environmental cause and potentially a familial susceptibility. What do I mean? Well, even when I can't find a hereditary cause, I do know that there are families where cancer clusters. You and your family share both your genes and your environment. So, in these familial cases, it's hard for us to parse out what exactly is the shared environment and what is the shared gene or genes. So, what sort of genetic tests are we doing in cancer care nowadays? We do both germline testing and somatic testing, also sometimes called tumor testing. Let me explain the difference. So, germline testing happens when we're looking for something that's present in all of a person's cells, something that someone was born with. Your germline are the germ cells are your sperm or your eggs. So the germline is what you got from your mom or your dad and what would be present in your sperm or your egg. This is typically ordered by a genetic counselor. This is looking for hereditary cancer. Examples of some germline testing are the panel tests that are offered by Myriad, Invitae, or Ambry Genetics. Compare that to somatic or tumor testing. That's looking for what's present in the cancer specifically. And what I mean by that is it's trying to characterize the specific tumor. This sort of test is typically ordered by a person's medical oncologist. And examples of tumor testing you may have heard of are Foundation One Medicine or Oncotype DX or Strata Oncology. Now, mutations that we find in these sort of tests can differ in what they can tell us. So, germline mutations, those that are found in the germline, only those can be inherited. And those, like I said, could be found in your sperm or your egg. And then if that gets fertilized, then be present in your child. They could also be found in your parents or your brothers and sisters or even your more extended family. Somatic mutations, well, sometimes we can see specific somatic mutations in, say, a lung cancer or a throat cancer that show the classic differences we see when there was smoke exposure or HPV. These can be indications of a possible environmental cause. But both somatic differences and germline differences are important in impacting clinical treatment. And I'm going to talk a little bit today about how both of these sort of tests can affect what your doctors do. So, how can genetic testing impact clinical care? Germline testing specifically has a lot of implications, and this is my area of expertise. So, first, when I see a person for genetic counseling, I'm going to take a very detailed family history, and I'm looking for features that suggest hereditary cancer. When I do find hereditary cancer, I may be able to provide a reason why cancer has occurred. And I can't underestimate how much this is sometimes really helpful for a patient. I encounter patients that take better care of themselves than I ever could. People that run marathons, that eat wholly holistic, and yet they're still sitting in front of me with cancer. And sometimes knowing that that was something that they were more likely to get in the beginning because of a mutation that they inherited from their parents can give them peace of mind. Genetic testing can also establish that person's risk for future cancers. What I mean by that is we can say if a person has a personal history of breast cancer, what their chance to get a second separate breast cancer down the road is. And that can be helpful to inform whether they want to do increased surveillance or a risk reducing surgery. So, surveillance for breast cancer, if I know a person's got a higher chance to get breast cancer again, can include not just the breast mammogram, but also a breast MRI, which used in conjunction with a mammogram can increase detection of early stage breast cancers. Additionally, a person might be offered the option of a risk reducing surgery. Risk reducing surgery, like a preventative bilateral mastectomy on the other side, can help a person reduce that upfront chance to get breast cancer down the road. Also, sometimes we find that these breast cancer risks can go hand in hand with another cancer risk, like, for example, ovarian cancer. And in those cases, a woman might elect to do a risk reducing oophorectomy, a bilateral salpingo oophorectomy, which is the removal of the ovaries and the fallopian tubes on both sides, as a way to reduce the chance that they ever experience ovarian cancer. Many of my patients are parents, and they come in primarily to find out what their child's risk to get cancer is, or their sisters or brothers, and they want to know what their siblings' chance to go through this is. Doing germline genetic testing can inform what of these genes or which of these genes is responsible for the cancer and allow for a target for family members to get testing. If I do a great big panel test on the affected family member in the family and identify which gene is at fault here, that provides a target to do genetic testing in other family members that ensures that we test for the right gene that's causing the cancer in the family. Finally, some of these genes can have reproductive consequences. A small subset of the genes that are on the panels that we do nowadays have the possibility where if mom has the mutation and dad has the mutation and they both pass it along, it can cause a much more severe presentation in their child. So doing testing on mom can inform whether or not we need to do testing on dad. For tumor testing comparatively, that's almost always done to do targeted therapy. Targeted therapy means we're going to specifically use the characteristics of a tumor or a cancer to exploit that difference and use the correct therapy that's the most effective against that cancer. So these sort of targeted therapies might be FDA approved, meaning that we already know that that's a really good use of that treatment. And many of these therapies are being used in clinical trials where we're still trying to investigate, is this an effective tool against this type of cancer? Two examples that I can highlight are things like PARP inhibitors being used for Fanconi's anemia genes, or immunotherapy being used for MMR or mismatch repair protein deficiency. Fanconi anemia pathway, those are things that we talk about with BRCA1 and BRCA2. MMR deficiency, those are the genes that are associated with a condition called Lynch syndrome. Both BRCA and Lynch syndrome are inherited conditions, but knowing that you have one of these inherited conditions can inform whether or not you might benefit from one of these targeted therapies. I'm going to talk a little bit more about the Fanconi's pathway as an example. So here's a picture of the Fanconi's pathway, and I promise I'm not going to go through all of this. The gist of this pathway is this process mediated by all of these individual genes making an individual protein creates the process of homologous recombination. Homologous recombination is just a fancy word for a fix to your DNA damage. So like I said a while ago, living on this earth will incur some damage to your DNA. No one's going to get out of here without some damage being done to their DNA. And our bodies have a process for correcting that damage when it happens. Homologous recombination uses the other copy of a chromosome as a cheat sheet for what to do to fix that damage. So if dad's copy of the chromosome gets damaged, we use mom's copy of the chromosome, the copy you got from your mom, as a cheat sheet for how to fix the damage that happened to the dad copy. That's homologous recombination. And it's a really effective way to correct damage that has happened to our DNA. So people that have a mutation in things like BRCA1 or BRCA2 or any of these other genes that are in the Fanconi's pathway, well, when they get tumors, those tumors are not able to do homologous recombination. So PARP inhibitors are a drug that impair the function of the PARP protein, which is an important protein in single strand repair. Why is that important? Well, if we've already knocked out homologous recombination as a way to correct our DNA, and you use a PARP inhibitor to knock out single strand repair to our DNA, you've left that cell with very few tools in order to repair the DNA. And therefore, that cell is at a disadvantage and is more likely to die. This process of using the fact that that cell is missing this homologous recombination pathway and knocking out the other pathway it's relying on to selectively kill that cell is targeted therapy. It's exploiting the difference in that tumor cell to make sure that it selectively kills that tumor cell. This is the goal of targeted therapy, to be more aggressive against the cancer cells and less aggressive against the other healthy cells in the body. So when should this testing be done? Well, when you do germline testing and when you do tumor testing, there's different indications for both. So I want to go through both of them separately. Tumor testing is primarily done at clinician discretion, meaning it's done when a doctor feels that the knowledge that would be provided by that test would be helpful in him or her making a clinical decision. I want to go over a couple examples. So sometimes we do tumor testing when we need to determine whether or not an early stage breast cancer is going to benefit from getting chemotherapy or radiation therapy. We might do tumor testing when we don't know where a cancer has started. So sometimes we find a cancer when it's already widely metastatic or it's spread to multiple organs, and the doctors aren't sure where that cancer began. Well, we can't be very effective in our treatment if we don't know what kind of cancer it came from. So we can use tumor testing to look at the characteristics of that metastatic cancer and see, does it bear resemblance to breast cancer? Does it bear resemblance to ovarian cancer? Because if we see differences that suggest that this is breast in primary, we can help by using breast tools against it or ovarian tools against it. Finally, when a medical oncologist is trying to pick the best tool to attack a cancer, knowing the features of that cancer can help them pick the most effective tool. Sometimes we need to go from agent 1 to agent 2 to agent 3. And by doing this tumor testing and sometimes doing it multiple times as a tumor mutates and changes over time, we can know the characteristics of that tumor and therefore the weakness of that tumor so that we can properly beat it. Compare that to germline testing, where there's a lot more written down guidelines of when this testing is appropriate. Many people have heard of the National Comprehensive Cancer Network guidelines, the NCCN guidelines. This is a widespread used guideline that dictates when is germline genetic testing appropriate. This, what you're seeing here on the slide, is by no means comprehensive, but to just highlight a couple of important red flags highlighted in the NCCN guidelines are things like breast cancer diagnosed at the age of 45 or younger, when there's 3 or more breast cancers on the same side of the family, when there's triple negative or estrogen negative, progesterone negative, and HER2 negative breast cancer at the age of 60 or younger, when breast cancer has happened in a male, when there's ovarian, pancreatic, or Gleason 7, which is aggressive prostate cancer at any age, or when breast cancer is seen in Ashkenazi Jewish ancestry. These are some red flags, not all of them, but some of the red flags that the National Comprehensive Cancer Network dictates may be an important sign that a patient would benefit from germline testing. But we at the Helen F. Graham use the American Society of Breast Surgeons approach, which says genetic testing should be considered for individuals with breast cancer without any of those other features. In other words, anyone diagnosed with breast cancer at the Helen F. Graham Cancer Center is offered the option of genetic counseling, and if they take me up on it, genetic testing. And that conversation includes the possible benefits of doing this genetic testing, as well as the possible limitations or downfalls. We talk about this because even when we don't expect to find differences, sometimes we're surprised. We also have to speak of what do we do when a germline mutation is seen to try to when a somatic difference, a tumor difference is seen to determine, is it germline? What do I mean by that? So most mutations that you'll see in a tumor specimen will be specific to that tumor, meaning that those are differences that have happened because of the cancer. But we don't know by just doing tumor testing which of those differences are germline. So in other words, we don't know off the bat which differences were present from birth versus which ones are just the tumor. The way to find that out is by doing germline testing, which is why NCCN guidelines recommend that when tumor testing sees a clinically meaningful genetic difference in a tumor, germline testing should be considered to see if it's germline, if it's present in all the cells of the body, or if germline testing is negative, then it's just the tumor. It's important to know that some germline mutations will not be present on the tumor. You can't assume that if it's not in the tumor, that person is negative. Why? Well, 2 major reasons. One, the scale and the accuracy, the technology used for tumor testing is not the same caliber as germline testing. The variant analysis that's done on germline mutations, meaning the thorough in-depth look to see is that a mutation or not, is not done as well or as thoroughly in somatic testing. So if we really are concerned that someone has an inherited BRCA1 or BRCA2 difference, it's still very important to do germline testing. And also, especially with widely metastatic cancers, cancer can cause downstream differences that make birth mutations not present in the tumor anymore. So as a cancer continues to mutate and change over time, you might lose the presence of that germline mutation. So it's important to know that somatic testing and germline testing each have their own implications and their own indications, but one does not replace the other. So finally, you might be thinking, well, this genetic testing is really interesting. Should I go order genetic testing myself? And the answer is, please don't. Direct-to-consumer genetic testing, or DTC genetic testing, is by definition any sort of genetic test that can be purchased without ordering a medical clinician. And so you might have heard of things like 23andMe or Ancestry.com. If you're doing this testing for a medical grade indication, if you are genuinely concerned about why your breast cancer has happened or why you have a family history of cancer, these sort of direct to consumer tests are not meant to replace medical grade genetic testing. Millions and millions of dollars every year are spent on things like 23andMe or some of these dietary genetic tests that'll tell you what foods to eat, what foods not to eat. Telomeres, which talks about how your telomeres, which are an important part of your chromosomes, correspond with a molecular age. So it tells you exactly how much you've molecularly aged. DNA Fit is an example of a test that'll tell you about a genetic predisposition to being a good runner or being a more endurance fitness person, or even genetic testing that exists out there for your dog. Millions and millions of dollars are spent every year on these tests, and I want to talk a little bit more about how they compare to the sort of testing that I might order in the clinic. Well, first, DTC testing is not subject to the same regulations that medical grade testing is. Some genetic tests are FDA regulated, meaning the FDA looks through them and validates them. Most genetic test is CLIA certified, meaning that the CLIA organization will go through and make sure that there's certain standards that are met when genetic testing is performed. Those same guidelines are not required for consumer testing that's meant to be a holiday gift, not a medical test. That's one of the reasons why correlative data is sometimes implied to be causative data. So examples of that are, there's genes that we know are important in the twitch function of a muscle. And these twitch function genes are then used to imply that people that have a more favorable difference in these genes, well, those are people that might be really prone to being good stamina runners versus more quick twitch, more fast sprinters. Obviously, someone's athletic ability is a lot more complicated than a single gene, but these sort of direct-to-consumer tests imply that it can all be boiled down to a single genetic difference. Even when we do testing on genes that are clinically validated, like BRCA1 and BRCA2, it's meaningful to be positive or negative for BRCA1 and BRCA2. These direct-to-consumer tests don't offer comprehensive analysis of these genes. What I mean by that is, for example, the 23andMe test will tell you if you have one of 3 specific mutations in the BRCA1 and BRCA2 genes. But that's not comprehensive sequence analysis. Sequence analysis means going through every single letter of that gene and looking to make sure that there's nothing abnormal about it. They simply look at 3 common errors that happen specifically in Ashkenazi Jewish individuals. And so outside of that ancestry, or outside of having one of those 3 mutations in your family, this testing is very, very limited in its benefit. The harm there is that if you didn't know any better and you got direct-to-consumer testing and you got told that you were BRCA1 and 2 negative, you might falsely be reassured when you could have another mutation that just wasn't one of those 3. The privacy safeguards that we rely upon in medical grade testing don't apply as much to direct-to-consumer testing. In fact, there's reason to believe that direct-to-consumer test data can then be sold to pharmaceutical companies or sometimes used in things like the catching of the Golden State Killer. If you've ever read about that on the news, the person who had committed these serial killings, his nephew, I believe, had used a direct-to-consumer test and had his data was available in a publicly available database that allowed authorities to realize that DNA at the crime scene was awfully similar to the DNA of this nephew and allowed them to connect the dots and find the killer. Direct-to-consumer testing, I mean, if you're not a killer, you would think, okay, there's no harm, but you really don't think about the fact that if those are publicly available databases, what other information could be available to other individuals. Finally, and I think most importantly, if you're going to do genetic testing, it's because you probably care about what this information means to your medical health. But if you do direct-to-consumer testing, it doesn't come with that built-in follow-up from a genetic counselor or a physician to help you get the medical follow-up that you need when you're positive. In other words, if you do a direct-to-consumer test, you might think, okay, well, now I can go out and get a mammogram or I can do this. But if you do a medical grade test, the genetic counselor, the doctor can help you get in touch with the right follow up, the right medical management, and make sure that you're offered the correct follow up for the specific difference that you have. Further, there's other concerns that come from this widely available direct to consumer testing. So, when you order a direct to consumer test, many of these laboratories offer the option to download your sequence DNA, meaning that in addition to the test results that they report, you can go online and you can download a large file that contains all the A's, the T's, the G's, and the C's of your data. And what's important to know about that is that it's meaningless unless you have some sort of reader. And there's lots of third party readers that allow you to look through that data and say, oh, we found this mutation or that. The problem is these third party readers can be wrong, and they're wrong quite a bit. A 2018 study looked at direct to consumer results that were validated afterwards at a medical grade testing lab. And they found 40% of the time, what was believed to be a clinically significant result was actually a false positive attributed to these third party genome readers. So, those people that don't go follow up and do a medical grade test to validate the testing that was done might falsely believe they're positive when they're really not. Further, the existence of these sort of mom and pop laboratories allow for the existence of genetic testing scammers. So these small laboratories that are not regulated by the FDA can crop up, and regulated by other regulatory agencies can crop up. And this allows for these genetic testing scams to go on. So what happens is recruiters will call, oftentimes seniors that are on Medicare. And we've had a crop up of this happen in Delaware, where these recruiters are contacting individuals based on publicly available databases of people that are over the age of 65 and tell them that for some reason they need genetic testing. They get a doctor that's in on the deal to say that genetic testing is recommended, and then a laboratory either runs a test or in some cases doesn't even run the test and gives the patient back some erroneous results. And then both the doctor and the laboratory can profit because Medicare can be charged for the cost of this testing. So we know that these scammers are out there. We're trying to do our best to make sure that when these happen, we do something about it, because these sort of scams exploit Medicare coverage, and it can be a reason why potentially Medicare might not cover this testing in the future because it's already been exploited. So it's this important understanding, it's this knowledge that we as clinicians that specialize in genetic testing really want to make sure that you are all aware of, so that genetic testing is used correctly and wisely. So thank you all very much for listening to my talk. I really appreciate the opportunity to share my expertise with you, and I welcome the opportunity to answer questions in the live session.